All right, welcome. In this explainer, we're going to build a really practical clinical framework for evaluating infertility. Now, if you're a medical trainee, this is designed specifically for you to give you a clear, systematic way to approach your patients. So let's get right into it.
First things first, what are we really talking about here? Clinically, infertility is all about time. For most couples, it's the inability to get pregnant after one full year of trying. But, and this is a key distinction, for women who are 35 or older, we shorten that window to just 6 months. The clock starts ticking a lot faster.
Okay, before we dive any deeper, I need you to burn this next principle into your brain. Seriously, it's that important. Infertility is a couple's diagnosis, not an individual's. You have to evaluate both partners at the same time because so often you'll find factors on both sides. Just looking at one person is a recipe for failure.
To really get what goes wrong, you first have to understand how it's all supposed to go right. So let's start with the female side of the equation and the incredible precision of the ovulatory cycle. The whole show is run by this really elegant hormonal feedback loop called the hypothalamic pituitary ovarian axis, or HPO axis. It all kicks off in the brain, where the hypothalamus releases GnR in these little pulses. That signal travels to the pituitary, which then releases its own hormones, making it the master conductor for this whole hormonal symphony.
In this slide, it's basically the sheet music for that symphony. You can see the follicle-stimulating hormone, or FSH, rising early on to grow the follicle. Then, bam, you get this dramatic mid-cycle surge of luteinizing hormone, or LH, that actually triggers ovulation. And right after that, progesterone takes over to prep the uterus. It's a beautiful, coordinated dance.
Okay, and here's a huge clinical pearl you can pick up just from taking a good history. That regular cycle you always hear about, it's not just some random number. It's like a vital sign for the reproductive system. When you see cycles that are super short or really long, that is a massive red flag that the main event, ovulation, probably isn't even happening. So what happens when this perfectly timed system gets thrown off? Let's dig into what that looks like, the most common ways ovulatory dysfunction shows up, and how we start to categorize it.
When we talk about amenorrhea, the absence of a period, we split it into two big buckets. Primary is for someone who's never had a period, which usually points us towards a genetic or anatomical cause. Secondary is when someone used to have periods and now they've stopped. And for secondary, look, before your brain jumps to some rare disorder, what's the first thing you must rule out? Always, pregnancy. Every single time.
All right, so let's keep building on this idea of ovulatory dysfunction and zoom in on the biggest player in the game, polycystic ovary syndrome. You are going to see this all the time in practice.
PCOS, at its core, is all about two things: too many androgens and problems with ovulation. What's happening is that the hormonal environment gets all out of whack, disrupting how follicles are supposed to develop. So instead of one egg being released, you get a bunch of small follicles that just stall out. And here's something you can't forget. PCOS isn't just a reproductive issue. It's a full-body, systemic, metabolic disorder that carries long-term health risks.
So how do we actually nail down a diagnosis? Well, we usually use what are called the Rotterdam criteria. You need to have 2 out of these 3 things: irregular cycles, signs of high androgens, or that classic string of pearls look on an ultrasound. But, and this is the critical part, PCOS is a diagnosis of exclusion. You have to make sure nothing else is causing these symptoms first.
In this image right here, it's a perfect example of a key clinical sign. This is hirsutism. We're not just talking about any hair. We're talking about thick, dark hair in places like the chin, chest, and back. When you see this on your physical exam, your brain should immediately scream PCOS.
Okay, with all that background, let's build a clear, step-by-step pathway for the female workup. How do we approach this systematically?
Your approach here has got to be logical. No random tests. So after your history and physical, what's step 1? A pregnancy test. Always. No exceptions. Once that's done, you'll get a core set of labs, TSH and prolactin, because thyroid issues and high prolactin can totally mess up the cycle. And then FSH, which gives you a direct window into how the ovary is functioning.
All right, let's play this out. The labs come back and that FSH level is high. What's your brain telling you? Where's the problem? In the brain or in the ovary?
A high FSH means the pituitary is basically screaming at the ovary to do its job, but the ovary just isn't listening. The messages are being sent loud and clear, but nobody's picking up the phone on the other end. This points you directly to a problem with the ovary itself, something we call primary ovarian insufficiency.
Okay, time to pivot, because remember what we said at the very beginning? This is a couples diagnosis. We need to apply that exact same systematic, axis-based thinking to the male partner.
And check this out. The logic is exactly the same as on the female side. With primary hypogonadism, the factory, the testes, is broken. So what does the brain do? The pituitary screams louder with high LH and FSH. But with secondary hypogonadism, the problem's in the brain. The signals aren't even being sent, so LH and FSH are low. It's the same pattern.
For the male partner, the initial workup has two non-negotiable parts. First, you need to check the hormones. That starts with a morning testosterone level, and if it's low, you repeat it to confirm. Then you get an LH to figure out if it's a primary or secondary issue. Second, at the same time, you have to look at the product, the sperm. A semen analysis is absolutely essential.
Okay, this next point is a huge, massive clinical pitfall you need to avoid. If a man has low testosterone but wants to have a child, giving him testosterone is absolutely the wrong move. Why? Because that outside testosterone tells his brain to shut everything down, including the FSH he needs to make sperm. You're basically giving him a male contraceptive. It's the opposite of what he wants.
All right, let's wrap this up and bring it all home. We've gone through the female side, the male side, and the diagnostic steps. Let's distill this down to the key takeaways you can bring to the clinic.
So if you walk away with anything from this, let it be these key points. 1. It's a couples diagnosis. 2. Evaluate them together. 3. For women, start by figuring out if she's ovulating. 4. For men, start with a testosterone and a semen analysis. 5. Remember, PCOS is a diagnosis of exclusion. And finally, always ask about fertility goals before you start a treatment.
And finally, as we finish up, I want to leave you with one last thought. Once you've got the labs, you've made the diagnosis, you've followed the algorithm, what comes next? Because at the end of the day, caring for the whole patient means looking past the lab values and remembering the human beings at the heart of this very personal journey.